Good afternoon. Welcome to UCSF's FCM Grand Rounds. We are very excited today. We have a fantastic session planned for you. Just a few housekeeping reminders before we start. My name is Margot Venner. I am the Vice Chair for Education, Family Medicine, and will be working on running these Grand Rounds today, along with our speaker, Dr. Ina Park, who I'm incredibly excited to hear from. But before we start, I just want to do a few reminders about the session. First of all, the session is being recorded. If you have questions or comments, please submit them into the Q&A. And we will reply either on screen or digitally. If you've missed prior Grand Rounds and you want to watch them, please, you can find us on YouTube or the UCSF Family Medicine website. Just as a reminder for today, we'll be having Dr. Park give a session for us, which I think will be really exciting. We will have time for some live Q&A for the end of the session. And then my goal is to finish a little bit early before 1 o'clock so everyone can get their next activities. For upcoming events, the next session will be in July, and we'll be canceling it due to the July 4th holiday, but please join us on Friday, October 6th. Dr. Tricia Elliott, who's the president of STFM and an incredibly engaging speaker, will be talking about promoting diversity in family medicine, and it will be a very educational and enjoyable session for sure. And if you have ideas about future Grand Rounds or you want to present at them, please email me and let me know. Our speaker today is Dr. Ina Park, who will be talking about her book, Strange Bedfellows, Adventures in the Science, History, and Surprising Secrets of STDs. Dr. Park is an associate professor at UCSF in the Department of Family Medicine and OBGYN. She has a joint appointment. She's also the medical consultant at the CDC in the Division of STD Prevention and the medical director for the California Prevention Training Center. In addition, recently, Dr. Park served as co-author of the 2021 CDC STI treatment guidelines and is a contributor to the Department of Public Health and Human Services' first STI National Strategic Plan, which is exciting. So today, for Grand Rounds, Dr. Park is going to ask us to consider this. Sexually transmitted infections have been hidden players in our lives for the whole of human history, affecting everything from world wars to the gay rights movements. But despite their prominence, STIs have been thought of as curious and often terrifying taboos for centuries, which begs the question, why do we know so little about them? Today, Dr. Park will be talking about her book, Strange Bedfellows, Adventures in Science, History, and the Surprising Secrets of STDs. She's planning to share stories of real people's sexual escapades and historical tales, along with the latest science of STI and HIV prevention. She's going to venture beyond the bedroom to examine the role that STIs have played in our lives and society. Her book has been hailed by the New York Times as joyful and funny and praised for its use of compassion, science, and loving playfulness as a way to diffuse the stigma surrounding these common infections. So with no further ado, I want to hand it over to Dr. Park. Thank you for joining us today.
Thanks, Dr. Venner. I'm so excited to be here. So I'm going to talk about STIs, what's happened with them before, during, and after the pandemic, and a little bit of history for you all, and talk about where we're going, as well as talk about what I've been doing with myself during my time to engage the public and reduce stigma around these infections. So let's see if my slides will advance. I have no disclosures. And so again, I'm going to go over some of the new epidemiology that was just released in 2021. And unfortunately, because of delays with surveillance, given COVID-19, the data reflect what was going on before the pandemic. But we'll talk about what happened to our sex lives during, and my predictions in my crystal ball about what's going to happen afterwards. And then we're going to talk about STI stigma from the past, as well as what I see it happening with it now. We're going to talk about sexual networks and some of the common myths that I think are really relevant to patient care about STIs, being a consequence of being quote unquote promiscuous, and what patients might believe about that and how we can counteract that narrative. And then we're going to talk about sexual networks and what really influences whether or not someone catches an STI. And then I'm going to talk a little bit about contact tracing, which I think everyone and their grandmother is familiar with due to COVID-19, but it actually started for the practice of syphilis control, and I'm going to talk about how it's evolved. And then I'm going to touch on racism and STIs, not necessarily a logical connection, but very highly intertwined. And then I'm going to tell you what I've been up to, in addition to the book, to use public engagement to reduce stigma, because that's really sort of what's gotten a fire lit under me in the past few years. So what was going on with STIs prior to the pandemic? Well, it wasn't good. I'll say that STIs were the most common reported conditions to the CDC prior to COVID, and they had been increasing for 6 years in a row. And in 2019 was the greatest number of STIs ever reported to CDC since surveillance began in the 50s. And you can look at the numbers here on the slide in terms of the scope of the number of infections we're dealing with. And I also want to direct folks, which I'm going to go into a little bit more detail later, about the 1,870 cases of congenital syphilis among newborns, which is a 300% increase in the past 5 years. And then very relevant, I think, to our patient populations is that half of reported STIs occur among people 15 to 24 years of age. And this year, this year as well, in 2021, the CDC estimated that 1 in 4 Americans has an STI at present. And that includes things like, of course, like human papillomavirus or HPV, which are incredibly common and, in fact, universal consequences of being sexually active. So I told you I was going to talk about a little bit more about congenital syphilis because it's probably the most important and pressing issue in my field currently. And we've had 128 deaths from syphilis and newborns, either stillbirths or deaths in the first 30 days of life. And so, in 1999, we had almost no syphilis in the United States, and now we have 43 cases with 43 states with at least one case of congenital syphilis. And in case you're wondering, it's not really a phenomenon that's necessarily affecting just one racial ethnic group, because rates increased more than doubled for all racial ethnic groups, and they increased by tenfold for Native American and Indigenous babies. And of course, there are racial disparities, as there are with STIs universally, with Black and Hispanic moms and Indigenous moms being more affected than other racial ethnic groups. And again, just to set the stage of where we are in place and time, about half of syphilis cases are among cisgender men who have sex with men, or men who have sex with both men and women. And then you'll see, in this pie chart in the teal and in the light purple, those groups that I just mentioned, taking up about half of the cases. And then just to point out over here on the left, there's, a good chunk of cases, about 17%, for which we don't know the gender of sex partners. And so these could easily be, gay or bisexual men, whether or not they identify as such, but folks that are sleeping with men or sleeping with men and women. And then again, to set the stage, I did mention earlier that we had a huge decline in syphilis in this country, and that was true for men who have sex with men, as well as heterosexual folks, and women in general are lumped together here as both women who have sex with women as well as women who have sex with men. But when we were in 1999 and 2000 was the nadir of syphilis in this country, and 80% of the counties in the United States had 0 cases that year, if you can imagine that. And then due to a combination of many factors, one of which is less fear of HIV with the advent of highly active antiretroviral therapy, as well as advent of the internet for hookups and the smartphone, as well as possibly HIV pre-exposure prophylaxis or PrEP. We had an increase in syphilis all around, which you can't see here, but particularly among MSM. So right now we are living in a time where syphilis rates among MSM are similar to what we had in the early 80s prior to the advent of HIV/AIDS. So that's all well and good. And what happened to us during the pandemic? Well, you can probably imagine. We did have some social and sexual distancing, at least at first. Although I have to say, some patients used sex like stress baking and they had more sex, but in general, from studies in Europe, as well as the US and Asia, this is a slide from a colleague of mine, Katie Renfro from CDC, and Everything here was a preprint and is now published except for one study, which was the Hensel study. But at any rate, you'll see in the dark teal, folks who had a decrease in their sexual activity, and then folks in the sort of medium teal color who had no change, and then a much smaller percentage had a increase in their sexual activity. But for the most part, people did reduce their number of sex partners and reduce their frequency of sex, even for folks who were actually living with a partner. And several studies of folks that were stably coupled revealed that, people were just, I don't know, too stressed out and worried to have sex, I suppose. So what happened is our sex lives went online. And so this is just data from the Match Group, which owns Tinder and Bumble and OkCupid. But Tinder, by the way, had its highest number of swipes ever on March 29th, and that was 3 billion swipes. And Bumble and OkCupid saw huge increases in their video calls, and OkCupid saw a huge increase in dates. Many of these were virtual dates and not in real life, but just to show you, people were still interested in connecting with each other, and many people downloaded these apps and are now able to meet in real life now that they're vaccinated. The other thing that happened, which you may not have been aware of, is that there was a national testing shortage, which I think artificially led to a decline in STIs. So as you also know, many people were not coming into clinic for routine screening, but even when they were coming in, many colleagues around the country reported that they did not have test kits. We were also at the San Francisco City Clinic, where I work, which is SFDPH's sexual health clinic. We also got low on testing supplies as well. And so 65% of labs surveyed by the American Society of Microbiology had a shortage of kits, and 46% by the end of 2020 were still short of supplies. So finally, we're back to baseline, where I have not heard of any shortages nationally. But if you can imagine, you couldn't even get a test. And so there was a lot of syndromic kind of management happening for folks who were coming in without and not giving a formal diagnosis and just treating based on our best guess of symptoms. So it's a little bit of the dark ages, unfortunately. So this is just very preliminary data from CDC, but in the second quarter of 2020, there was a 60,000 case deficit in gonorrhea. There was also a deficit in syphilis and chlamydia. And it looks like everything is caught up except for chlamydia, which, as you all know, is mostly asymptomatic and is detected by screening. So looking into my crystal ball, I highly recommend that everyone sees this ad by Extra Gum that shows what's going to happen after the pandemic, where literally every person runs out of their toilet paper filled den and just hops on the first person that they meet and starts a makeout session with them. And, just a couple weeks ago, there was a story in CNN that condom sales have certainly gone up. And so I think that there's going to be lots more sex. We are seeing volumes comparable to prior to the pandemic and the STD clinic. And even if people buy more condoms, I think we're going to have a resurgence of STIs. So I have job security, but it's just something that also as primary care physicians that we want to be aware of. And this is a great time to assess sexual history and figure out, what people are up to and whether or not they need testing. So I'm going to launch into some of the concepts and stories in the book, and I really tried to choose the concepts that I think are most relevant to folks who are in family medicine. So I'm not going to talk about how you write a book, but for anyone who is interested in that, I am going to have my email address at the end, and I have a bunch of little pieces of content that I can send you about how you actually get into the process of writing a book and getting it published. But in terms of why, so I am a family physician by training, and I've been with the department since 2007. But for most of that time, I was contracted to work at the state health department. And all I saw were STIs getting worse. I just saw the stigma around these infections not budging with my patients, at least. And I felt like I wanted to do something to try to counteract the narrative of STIs as being a disaster, a punishment. And I wanted to use storytelling and humor to try and illustrate some of the more fascinating aspects of these infections and draw people in to get more curiosity about the topic and hopefully increase some conversations about it as well. So that's the why. And so the first thing I tackle throughout the book is talking about stigma and how it appears and rears its ugly head throughout history around STIs. And I'm going to focus more. So this is a sort of layers of stigma, and this really can apply to any topic, but this is from an HSV or herpes advocate. And I'm going to focus more on things like the macro system, sort of the cultural influences that lead to STI stigma, as well as the exosystem. So the media and its influence on STI stigma. And then obviously that leads to intrapersonal, the patient in front of you feeling internalized, shame and sexual stigma. So this is a painting by Edvard Munch of a baby with congenital syphilis. But, for a long time, there have been, thoughts and the Judeo-Christian sort of values around marriage between one man and one woman being the norm and the only acceptable sort of way that sex can happen. And that if anything happens outside of that norm, for example, then there will be God's judgment, and God's judgment can be something like an STI. And then even in World War I, we started with the language of people being clean, right? And so I'm going to talk about this quite a bit. This sort of language that we use and that patients still use today, by the way, of saying, I don't have an STI, I'm clean, started in World War I. And just as an FYI, we lost 7 million person days due to STIs. And really the only thing that caused a larger loss of duty was the 1918 influenza pandemic. So this was a huge issue on the government's mind, which is why they started releasing these propaganda posters, discouraging folks from getting an STI, discouraging folks from seeing sex workers. And I'm going to show you how that continued on when we got into World War II as well. But first, everyone here knows William Osler, sort of the grandfather of modern medicine. He talked a lot about stigma as well in various speeches that he gave, but mentioning that centuries of silence had made this disease taboo. And so folks who were dying from syphilis-related complications would avoid going to the hospital, would avoid going to their family doctor. And so there was, certainly an undercounting of infections. But at this time, he was giving a speech in London, and at this time they had over 10,000 deaths of babies due to congenital syphilis. So the scope of the epidemic was larger. And in the US at that time, 1 in 10 adults were thought to have a positive syphilis serology, if you can believe that. But, one thing that he mentioned was that with all this stigma, and even with folks who were dying of, syphilis, not wanting to have their death attributed to syphilis, there was sort of despair in terms of statisticians not really being able to know how bad the epidemic really was. And this was obviously something that played out when we came up with HIV as well. So there was a war on syphilis launched in the 30s. With the Surgeon General basically released 125 articles in major newspapers. So it was like sort of a blast of trying to shine a spotlight on this infection. And the Time magazine cover actually, you'll see, has his picture and mentions that he is trying to target something that is a taboo, but never even mentions syphilis on the cover, although it is mentioned in the body of the article. But this is the thing, just to set the stage about where we have come and why things are so stigmatized still today, is that we have had a hard time talking about these infections for a long time. And then I think these are probably the most well-known and famous, posters in terms of propaganda and anti sort of VD statements. But this is really the heyday of posters that shamed and blamed soldiers and would also put a lot of guilt on them that, if the war was going to be lost, it was going to be their fault because they got VD, calling them a saboteur, saying there's no medicine for regret, and that you're gambling with the freedom of our country with your carelessness. So this is obviously a setup for folks feeling bad about getting an STI. And before the advent of HIV/AIDS, herpes was really front and center in people's minds because we had the development of serology tests, so more people knew their herpes status. But I mean, Time magazine called it the Scarlet Letter. And this ad selling acyclovir, which came out, in the early 80s, obviously is somewhat stigmatizing because it says the hardest thing someone ever had to do was tell their partners they had herpes. So this is obviously a setup for people feeling bad about it. But these Time magazine articles, there was actually 2 of them, interviewed people saying, I am unmarriageable, I am poisoned, people don't want to work with me when they find out. I mean, just terribly stigmatizing infection. And that really continues today. One of the things I talk about in the book is the fact that, contestants from The Bachelor are routinely screened for STIs, and they are rejected if they come up positive for HSV antibodies. And so one thing I do mention as well is that the test that they use has a terrible positive predictive value. And so with low positive results, those results are false positive about 50% of the time. So not only are they keeping folks from finding true love on reality TV, but they are saddling people with a false positive diagnosis. And as you all know, because you consume the media, is that herpes is the butt of jokes in most Judd Apatow movies, Saturday Night Live. I mean, it's used as a comedic tool. And that, I think, helps perpetuate the stigma that still exists around this infection. And I want to take us and compare it to HIV. And in many ways, I'm just going to tell a brief story, which is not from the book, but just from my own personal experience, is that I had a man who was living with HIV for more than 20 years. And I told him that he had herpes as the cause of a recent genital ulcer. And he started crying. And he said, I don't know why I'm crying, because I didn't even cry when I got my HIV diagnosis, but I'm feeling so terrible for some reason. And so I really think, unfortunately, HSV in some ways is more stigmatized than HIV. But first, certainly when it first came around, it was, often referred to as a gay plague. People even called it gay cancer for a while, and it was even called gay-related immune deficiency. So, these articles, these are actually from Australia, but they're saying, it's spreading worldwide to innocent people because folks who were MSM were certainly not innocent, right? According to the sort of judgment of the day. But I want to say that due to tireless advocacy, as well as many celebrities and other folks coming out as spokespeople in favor of HIV in a supportive community, we are now at a point where undetectable equals untransmittable, or U equals U, is a tagline that is used in many communities around raising awareness around HIV. So we've really come a long way with lots of funding, the advent of effective therapies, and a lot of advocacy. But we are not quite there for HSV, unfortunately. So here's probably one of the most relevant, I would say, concepts in the book that I talk about, which is around sexual networks. And the way I start is to talk about 2 patients that I had, one of whom had about 25 partners in the past 3 months, and then another person who had had 2 partners. And the person with 2 partners ended up with repeated bouts of gonorrhea, and the person with 25 partners had nothing. And so, one of the myths that really feeds stigma is that STIs result from quote unquote promiscuity. And this is just a sexual network from a colleague from University of Washington. A person can say that they have 1 partner, but the risk that might come into that relationship obviously differs extremely depending on the number of sexual connections that the other partner might have had, in the past few months. And so I think one of the most important messages, because patients often feel bad or guilty when they get an STI, is that whether or not someone catches something is really a consequence of their network and whether or not people are having concurrent partners in that network. and not just the number of partners that you sleep with. Because it's more not that people just feel bad about themselves, but when they hear someone else has an STI, they immediately judge them for saying, oh, you know, that person is promiscuous or quote unquote a slut. And oftentimes, whether or not you catch an STI is due to factors that are somewhat out of your control. And when people are attracted to folks of a very specific race or gender identity, for which there are not very many people in that particular group, then those sexual networks might be very tightly knit with fewer degrees of separation. So if an infection gets into the network, then it can be spread much more efficiently. I'm going to show you what I mean by that. So the way you connect with your partners also has a huge influence on whether or not an STI might enter the picture. So the patient that I talked about who had had 25 partners was practicing serial monogamy. Even though some of these relationships only lasted, you know, one night, he was having partners, ending a relationship and then starting a new one, and then ending that one and starting a new one, and testing at different points in between. So the thing is that if you get an STI, which is the person over here in letter D, then the people that preceded, you know, that partner are not going to be at risk. But when you have the same number of partners, but you're connecting with people concurrently, that is the setup to facilitate the spread of an STI or HIV in a network. So the person I told you about that had 2 partners was going back and forth between Las Vegas and San Francisco and sleeping with one person in each of those locales in a pretty short time period. And condomless sex was what was going on. And so an infection was sort of ping-ponging back and forth, and he was continually sort of getting reinfected because the other folks that he was having sex with also had other partners when he was not around. So again, this whole concurrency leads to greater risk of STIs. So one of the really important things to ask your patient is, if they say, I only have one partner, is it possible that person's having other partners at the same time that they're having sex with you? And so that if they say yes, then you can actually sort of think of that person as having multiple partners because of their sexual network. And just to give you an example, this is a modeling study around HIV, is that even a small increase in folks who are having concurrent partners will greatly increase the connectedness of the network and the risk for contracting HIV if you have sex in that network. So even I'm just going to use an example here of a network where 56% had 2 or 3 partners and you just increase that by 8%, the connectedness of the network actually increases by 20-fold. So even a small increase in concurrency greatly increases the connectedness and the risk that if an STI or HIV enters the picture, that somebody will catch it. And by the way, please put your questions in the Q&A because Margot is going to be collating them and we'll talk about them afterwards. Okay, so then I'm going to talk a little bit about contact tracing. And this is, okay, not quite as relevant to your practice, but something that I wanted to make a plug for because it's a wonderful thing when you diagnose someone with an STI, especially if it's syphilis, to say that a contact tracer may be reaching out to you so that when folks hear that from their clinician, they are less concerned or they feel like it's less intrusive when the health department actually calls them. So I just wanted to show you an example of us. I tell stories of contact tracers from the 70s to the present day. And this is John Potterat, who ran the STD program in Colorado Springs for many decades. And I just wanted to point out a couple of elements of this. First of all, there's no computer and he's on a rotary telephone. And there's an ashtray here because they smoked in the health department in the office. And never mind his mullet and his tie, but behind him is a bumper sticker that says support your local hooker. So obviously language was really different. And contact tracing then involved primarily him hanging out at biker bars as well as with sex workers and giving out his home phone number to folks so that they could reach him at all hours of the night, because they had no cell phones, they had no email. And so being a contact tracer really involved being embedded in your community so that folks knew you and you were seen by community members, and they would then get in touch with you if a new drug entered the scene, or if something was going around, you were a trusted entity within the community. And these days, contact tracing in the 2020s often involves folks being remote and people not actually knowing the full name or the phone number of their partner. So it is very challenging, much more challenging now, because sometimes people have a first name and maybe an online handle for their partners. So it might be like, cute guy in SF or something like that, and a first name. And if the encounter didn't go well, sometimes one of our patients might delete the person's information and actually not be able to find them if they get exposed to syphilis and a contact tracer needs to contact partners. You get a lot of dead ends when we're doing contact tracing in the age of dating apps, because of the fact that it allows for a little bit more anonymity, and then that is the detriment to the detriment of folks who are actually trying to do the case finding after the fact. And so whether or not, as folks may or may not have heard, health departments received $1.1 billion in appropriations by President Biden's administration to increase and make more robust the contact tracing system in the US, but whether or not it will continue to work for HIV and syphilis remains to be seen. I mean, I do think we're going to keep at it and then evaluate and see, but it's becoming really difficult in the age of apps to do it. Okay, I think I'm doing okay on time. I'm going to touch on racism and STIs because, as you may or may not know, a lot of the disparities that we have in STIs stem from structural racism. Okay, so what do I mean by that? The thing is in studies, and these were studies primarily done in both white and Black populations. So I'm sorry that I don't have a lot to say about Hispanic and Asian populations, or Latinx populations, excuse me. That sexual partnerships, or this idea of like equals like is attracted to like, does occur. And so in particular, Black women, about 90% of Black women in several studies report partnerships only with Black men. And so, and for white women also tend to have partnerships with white men. And then of course there's mixing back and forth, and in particular areas of the country, there's lots of mixing. But if you can imagine that if there's, a strong preference of like Black women to be with Black men, for example, that removal of men due to violence and mass incarceration distorts sex ratios in communities. And there's actually much research done by both folks here at UCSF, as well as Michelle Andrasik at University of Washington, showing that you have communities where sex ratios are greatly distorted. So instead of a 1-to-1 relationship between men and women, you have, 0.7 men for every 1 woman. And Michelle Andrasik actually calls this sexual decision-making in the absence of choice, which means that Black women, there are simply not enough men to go around. And this leads to greater rates of concurrent relationships for men, which, as we talked about before, leads to, higher risk of HIV and STIs. And the concurrency, will overwhelm basically, even when folks, reduce their number of partners or use condoms, having lots of concurrent relationships going on will increase risk. And therefore we have, huge disparities in incidence of bacterial STIs and HIV among, Black communities, as well as with lower disparities in Latinx communities. So it's just, one of those things to think about, how racism has so many downstream effects that we don't necessarily think about when we're, testing someone for STIs. And then I do go into some of the exploitative research that happened. And I think most people know about Tuskegee, which is actually the second study on this slide, but I think less people know about the Guatemala experiments done by some of the same researchers, by the way, where there was deliberate infection of soldiers, prisoners, and sex workers with gonorrhea to test for new prophylaxis and treatments with, by the way, they didn't find any. So all of these unethical experiments did not lead to new scientific information. And then lots of syphilis diagnostic procedures such as LPs or cisternal suboccipital punctures were done on orphans and the mentally ill without their consent. And so, both of these sets of experiments are often used to, or pointed to as reasons for medical mistrust in this country. And the interesting thing is that someone actually looked at this, which I talk about in the book, and actually wanted to look at the legacy of Tuskegee. And this is Ralph Katz from NYU. And his concern was, will we be able to recruit minority populations into research studies? Because is the legacy of Tuskegee and the memory of Tuskegee so strong that it will actually prevent folks from participating in this research, even for generations after the fact? And many people have said that that is the case. And he wanted to know actually how many people could still remember Tuskegee. So he actually did 2 random digit dial surveys with actually pretty high response rates for these kinds of things, with large sample sizes of more than 1,100 people. And you can see the areas that he conducted his studies in, with his second study also including Latinx folks in San Juan, Puerto Rico. And he asked people, have you ever heard about anything that would affect your trust in medical research? And if so, what were those specific things, studies or whatever that you heard about? And then later he would say, have you ever heard about something called the Tuskegee Syphilis study? And what have you heard? So the answer might surprise you, actually. About half of folks had heard about something that would make them, mistrust or affect their trust. But 90% did not actually name the Tuskegee Syphilis study. Now, of course, you can take a look at this figure from his study, and you can see that Blacks were more likely to definitely identify the Tuskegee Syphilis study, but this was not a statistically significant difference. But I think, the conclusion he came to was some researchers were saying, I'm not even going to bother and try to recruit people of color because of Tuskegee, they don't trust us. And so we'll just, do what's easier, which is recruit majority communities and not try to recruit minority communities. And sort of his take home message around all of this is that, most people don't identify Tuskegee, and so don't use Tuskegee as an excuse not to try and recruit communities, but that obviously many folks have heard of other things or have general mistrust of medical research. And in fact, in a follow-up study, most people of color said they were not less likely to say that they would participate in research, even though they did say that they were, less trusting in general. So I think that, the take-home point was that folks needed to try a little bit harder in minority communities because of mistrust, but Tuskegee itself was not necessarily what was, the only thing causing that medical mistrust, and that there were obviously many other issues that had been going on since 1619 that would, including slavery, et cetera, that would affect people's mistrust in research. So to end, I'm just going to talk a little bit about public engagement to fight STI stigma. And so I wrote this book in order to try to increase conversation and get people more interested and fascinated with STIs, but I've also gotten excited about doing some public engagement. And I think ways that folks can do this as well is to speak out against negative behavior and statements on social media and to correct negative language. And that is the case for patients as well, is when someone says like, oh, I'm clean, to say, oh, we don't really say that anymore about STIs. We really say people are positive or negative and not use the word clean anymore. And And really the other thing I think that family docs should and can do, and that I try to do all the time, is normalize STIs and the take-home messages that we all get them, especially HPV. But to say everyone gets an STI, it's nothing to be ashamed of. And one thing I'm going to talk about a little bit, which is the final bullet, is I encourage folks when the opportunity comes up to engage with journalists, and I'll show you a few opinion pieces that I've been writing to speak out as well. So one of the things that I got involved with was starting this campaign called Face of an STI and Stop Stigma, which was done at one of our international conferences, because someone was saying on Twitter, well, no one wants to be the face of an STI. No one wants to be an advocate for STIs. And I said, well, I do. So I partnered with this company called Giant Microbes, who makes these plush stuffed STIs that you guys may have seen, and also other infectious diseases. And we set up a photo booth and invited folks at this international conference to come and pose with these giant STIs, and we posted it on social media, on Twitter. And so we had folks come from all over the world, you know, from like an 80-year-old Canadian First Nations elder to, you know, folks in their 20s who were doing STI research. And, you know, we had a 3-day campaign. We had, you know, lots of Twitter impressions with over 79,000 unique users reached. So just a blip, obviously, in the Twitterverse, but, you know, something that was not very high cost, that sort of could be done to sort of show people who are interested in and excited to be associated with STIs. The other place that I've gone to a few times is Reddit. People, just so you know, people are crowdsourcing their diagnoses of STIs and showing photos on Reddit. You'll see this was in JAMA, showing an increase in people posting on the subreddit called STDs, and the number of posts per month, which has gone up steadily. And I think, I haven't looked for 2020, but during the pandemic, I'm sure it got worse. So I got on with a colleague of mine, and we did something called an Ask Me Anything. And this is something really that anybody can do if you get in touch with a moderator, to say you get on for an hour or an hour and a half and say, we will answer anyone's questions about whatever topic. We got over 300 questions in an hour. And it was a way to engage with people. And every time we gave a message, we tried to normalize and be sex positive and hopefully help counteract the narrative around STIs. Another thing that I'm trying to do on Instagram is partnering with folks who are already really influential in the field. This is Shan Boudram, who has 480,000 followers, and she does, you know, all types of sexual health work. So we did a video about U equals U. It has over 200,000 views. You know, it's actually 205,000 views as of last week. And so again, this is something simple that folks can do, is if you have someone you follow on Instagram who has a large following, who is interested in one of the topics that you're interested in or passionate about, messaging them and saying, hey, do you want to do a live chat on Instagram about this topic, and I can answer questions, and they can go live. You can go live with them on social media and answer folks' questions right then and there. And then engaging with journalists. This is a double-edged sword, because you often don't get to see, you know, they quote you. You don't know if they're going to represent you well or not. The journalist often doesn't have control over the final product, the editor does. And so this thing that I did for BuzzFeed, they said experts predict a slutty summer, which I would never have used that language in a million years. So, you know, to be associated with that title was not ideal, but, you know, a lot of folks saw this piece, and the rest of the messaging was very sex positive. But this is one of the things about engaging with journalists. It gets the word out there, but you don't have total control. But where I would encourage people to write opinion pieces for the lay press, it's a great way to get your idea out there with a broad readership. The Op-Ed Project website has such great resources because there's a formula to it, and it's easier than writing a journal article, trust me. And these are 3 pieces that I've published, and there have been many rejections along the way, but I'm going to share my email address. Oh, and this is just a picture of me. You can write a book as well. And I want to share my email address for folks. If you want to write a book, or if you want some more advice about writing for the lay public, please email me, and I'm happy to hop on a Zoom with you for a little bit and send you some of the resources that I have. And that's it, Margot.
Thank you, Ina. That was a fantastic, engaging presentation with so much for us all to think about. And by the way, we have a lot of those stuffed plush STI toys around our house too.
Yep.
There's some great questions from the audience. We may not have time for all of them, but I'm going to at least ask you the first one that we have time for, and then we'll see after that. The first question was asking from a primary care perspective, do you have some statements or scripts to help you in patient visits when diagnosing or discussing STD histories, which can help destigmatize STDs as well as encourage and empower sexual health?
Yeah, so I mean, I don't have a written document, although now you're giving me an idea of something else that I could do actually. But I think the first thing I do when I'm giving someone an STI diagnosis is normalize and say, oh, just so you know, every sexually active person gets an STI. And so that's number one. And the other thing I do is, I give them, depending on what STI we're diagnosing, and if it's a bacterial STI, they're going to get treated. And then, 7 days later, they are fine to have sex again in terms of from an infectious disease standpoint. So at the time I'm giving them diagnosis and prescribing their treatment, I'm also telling them, hey, by the way, in a week, you're fine. And I encourage them to go out and become sexually active again. Because a lot of people, will have that moment of pause and say, I'm tainted, or they'll even say like, I feel dirty or whatever, I feel ashamed. And so that's the moment. And even if they're not saying it verbally, to actually encourage them to go out and be sexually active. And then for HSV, for herpes, sometimes I'm in an STD clinic, so I don't schedule a follow-up appointment, but those sessions sometimes need more time than you might have in that first encounter. So it sometimes requires a follow-up visit to really get into how sex, hearing from the doctor, I want you to go out and have sex again and enjoy your sex life.
Dan Ciccaroni, where he asked, what about partnerships with social media / hookup sites? There must be logically savvy with too much with anonymity. Can legislation help foster this?
And not so that the health department can actually message people within the app. And so that is one way that that folks have been doing that. They are not, though, yet, and there's some sort of federal regulations about this, going to necessarily give identities if an online, like share identities with a third party like the health department. So that I think would require some sort of legislation because of privacy issues. But at least, many of them, in particular Grindr, have been open to having different health departments with their own profiles on there. And so that has greatly facilitated getting in touch with people, because no one answers the phone anymore, as you know.
I said that was the last question, but I think the final question is so related that if you don't mind, I'm going to sneak in one more. This is from Nicole Holm, and she asked, disease intervention specialist, i.e. STI contact tracer metrics, often place a high value on the number of contacts elicited, but patients frequently value their network and feel a sense of responsibility to notify their partners themselves. Ensuring partners are notified is very important, but so is a long-term trust and respect for the health department and not feeling like they push past a certain point. How do you see this balance?
So, when I'm diagnosing somebody and I'm in a health department clinic, so then the contact tracers are right there, and we do a warm handoff type of thing. But if they say I really don't want to tell my contacts to a third party, then I actually direct them to sites. So they could either text or message people, but there's also, tellyourpartner.org. and InSpot are two sites where you can actually do anonymous web-based notification about an STI exposure. And so I direct people towards those sites. And you just can't push too hard because, as Nicole pointed out, like, you want people to, then trust the health department when you really, when you really need them. And so it depends, on also when HIV is involved, then, I will spend some time doing some counseling or whatever, but I don't push too hard. I mean, we have to meet people where they are. I think that comes with, the territory with any counseling around health and healthcare. But in particular for this, I will try to get them to notify partners either that on their own or then anonymously.
Wow. I want to thank you, Ina, for an incredibly exciting and thoughtful presentation. There's a couple questions that we are not going to have time to answer live, but I would really, Ina's been super generous with her time and was sharing her email. I would really encourage you to reach out to her to ask her questions about, well, this topic in general, or just the role of STI treatment and stigma in public health and healthcare, writing a book, anything else. I really appreciate your being here today. Thanks to everyone who joined us. Again, this session has been recorded. If you've missed some of it, please feel free to watch the rest of it on the department website or on YouTube, also prior grand rounds if you've missed them. And we hope that you will join us in August for Dr. Tricia Elliott. But most importantly, I really want to express our thanks to you, Ina, today for giving us a truly inspirational talk. Thank you so much.
Thank you. It was great. Bye,
Thanks.
everybody.